Hello everyone. In this video, we'll discuss about a phacoemulsification in a morbidly obese patient with a total intumescent cataract. Our patient was a 49-year-old female who was weighing 130 kilogram with a total intumescent cataract. So, what are the challenges in this case? Since it is a total intumescent cataract, the intralenticular pressure will be high, so rhexis will be a challenge. And because of the patient's obesity, the vitreous pressure will also be increased, so that will also be a challenge. So, the anterior lens capsule is stained with trypan blue. Next, we have to fill the anterior chamber with viscoelastic. A trick here is to use high molecular weight cohesive viscoelastic to counter the high intralenticular pressure. So as you can see, I am filling the anterior chamber with cohesive viscoelastic. Now I am initiating the rhexis. So in a total intumescent cataract, we can do rhexis in a couple of ways. One is the spiraling or bowling technique, and the second one is two-stage rhexis. So what I am doing here is a modification of the two-stage rhexis. I'll complete the half of the rhexis. Then I'll do irrigation aspiration of the loose cortical fibers. So as you can see, I have completed half of the rhexis. Now I am creating a side port for my irrigation probe. So now using bimanual IA, I am aspirating the loose cortical fibers. So this will aspirate the loose cortical fibers both in front and behind the nucleus, so that the intralenticular pressure will be reduced and the bag will be nicely decompressed. So once you have done this, you can do rhexis in a controlled manner. So now a challenge to do rhexis here is because we have aspirated the loose cortical fibers, there won't be support for us to do rhexis with a cystitome. So I am using a Haldipurkar forceps to continue the rhexis. I am giving tearing force in a centripetal direction in order to complete the rhexis. Now we have a adequately sized circular rhexis which is central. Since this is a total intumescent cataract, hydrodissection is not needed because the nucleus is already free. Now we are in pre-phaco mode. We are aspirating some more loose cortical fibers. The machine which I am using here is Alcon Legion. Now after pre-phaco, the anterior chamber is filled with viscoelastic, and the mobility of the nucleus is confirmed by rotating it. Now we are proceeding with the nucleus management. The technique which I am using here is divide and conquer. So since this is a total cataract in a young patient, the trenches need not be very deep. A depth of 70% will be enough to achieve crack. So as you can see, I am creating 4 trenches. Remember, the depth can be 70%. Now I am refining the trenches. Once the trenches are of adequate depth, we can do cracking of the nucleus. So for cracking, both the instruments should be as deep as possible, and then lateral separation movement has to be done. So one crack has been done. This is the second crack. I am planning to do 4 cracks here. So second crack has been achieved. This is the third crack. Both the instruments are placed as deep as possible and lateral separation is done. Now once we have done this, we have 4 nuclear pieces. Now in quadrant removal mode, we are emulsifying these 4 pieces. The first piece has been emulsified. This is the second piece. Remember, phacoemulsification has to be done in a controlled manner. This is the third piece being emulsified. The last piece has to be emulsified in a very controlled manner because since the patient is obese, the vitreous pressure will be high and the PC tends to come up. So the last piece has to be emulsified in a very controlled way to prevent posterior capsular rent due to surge. Once all the nuclear pieces have been eaten, I have decided to remove the fine epinuclear plate using IA probe. So using bimanual IA, the thin epinuclear plate is first freed up and then aspirated. Now I am switching my hands. so that I'll aspirate the fine epinuclear plate in my right hand side. As you can see, I am feeding the epinuclear plate using my irrigation probe into the aspiration probe. Now once this is done, there are very fine cortical fibers. Now in a case of obese patient, removing this fine cortical fibers will be a challenge because of the high vitreous pressure. The PC will tend to come up, so we have to be careful during IA. So in order to loosen the cortical fibers, I am injecting hydrojets. This will nicely loosen up your cortex so that IA will be easy. So after giving hydrojets, I am aspirating the cortical fibers. At this point, I decide to inject the intraocular lens and then continue with my eye. Remember, in obese patients, the vitreous pressure will be high and the PC will tend to come up. So once you inject your intraocular lens, that will act as a protective barrier, so that the PC is not caught during your IA. So the IOL is loaded, and this is a 2.2 millimeter phaco main entry. This has to be enlarged to 2.8 to 3 millimeter in order to inject the intraocular lens. So now the main port is enlarged to around 3 millimeter. Then we are injecting the intraocular lens. I inject both the leading and trailing haptics into the bag so that dialing is not needed. So after injecting the intraocular lens, we are proceeding with our IA. So one problem with this approach is some cortical fibers can get stuck between your intraocular lens and the posterior capsule. So one such cortical fiber is stuck there. So what I am planning to do here is I want to inject hydro waves under the intraocular lens in order to bring the free cortical fiber above it and then aspirate it. That is what I am doing now. I am depressing the main port and injecting hydro BSS, so that will bring the free cortical fiber above the intraocular lens, which can then be safely aspirated. So we are doing further IA of all the loose cortical fibers. So IA of all the remaining loose cortical fibers have been done, and simultaneously visco wash has also been done. So now we can close this case after injecting intracameral moxifloxacin.